Hi, friends. Welcome to Teens
Hi.
CORE. Welcome to Dr. Agim. Yay! One of
Yay.
our revered T4 speakers. Dr. Agim is an amazing pediatric dermatologist that I had the good fortune of working with when she was in her fellowship at Texas Children's, and we were at Baylor together. And I will tell you, she has some of the luckiest patients in the world because she not only brilliant and has a totally, I am sure, memory that can just absorb like a sponge. Everything she reads is already in there and embedded, but she can apply that clinically. And she is an astute clinician that picks up the smallest of signs on patients and then uses all that encyclopedia of derm knowledge that's in her head to make these just rare and amazing diagnoses that change these kiddos' lives. So Dr. Agim, I'm so glad you're back talking
Oh,
on.
it's a pleasure. It's a pleasure. It's
Yeah,
always fun to do these with you. And, preparing for it is another learning opportunity. And I'm so glad that we can talk about the boards that are coming up for the residents and teach them something, and getting them ready, hopefully, so they can be our future generation of dermatologists that are board certified.
that's right. And you have two behind you,
Yes, I have
dermatology
two special
residents.
guests today. I'm going to have them introduce themselves. Susie.
Hello, hi. I'm Suswana J. I am a first or incoming second year derm resident here in the Dallas area with Dr. Cockrell in the new derm program, Lake Granbury Medical Center. Nice to meet you all.
And Marissa.
Hi, I'm also almost a second year derm resident and same program with Susie.
And it's a privilege to work with them. It's a small program, it's a new program, but they're brilliant and they're eager to learn.
And that is great because they have one of the best teachers. So yay. And you guys just saw a
Yay.
patient with potentially EB today, epidermolysis
Yes, I was
bullosa.
telling her about the picture we saw with EB and his dad. Yeah, yeah.
Yeah. So I'm glad you're out there teaching this next generation and you guys do give us hope. So everybody tuning in, thanks for tuning in. And we know that, passing our boards is really important, but really the whole reason we do this is to take good care of our patients. So
Yes.
that's what this
So,
is about.
um, I remember, when I was a resident, one of my professors, one of the things he said, we used to dread exams. We didn't like exams, even though we're all really good test takers in dermatology. It wasn't the most fun thing to do, but whenever we had that looming deadline, we knew we had to study, and we always wanted to know what should we be studying? What should we be learning? What is high yield, right? I remember him saying after a particularly difficult exam that the exam is not meant entirely for torture. It's actually supposed to teach you so that you learn from both the questions you get right and the questions you get wrong. Because in our program, right after the exam, we would all together with our professors and attendings go through the questions and answers. That way you could understand the exam, understand the questions, understand why maybe you selected an answer that you shouldn't have, what the bait and switch was, or what the nuances were. And so it got me thinking about exams in a different way as another way to teach or another way to learn rather than just a rite of passage. So my goal with this lecture was to try to continue with that. I have written exam questions and sample questions for both review courses and for review books and for different stages of the exams we take in dermatology. But for these, I crafted brand new questions based on the American Board of Dermatology's learning list. So they have listed on there the conditions that they want the residents to know for the competency exams. And so I went through those topics and tried to create new questions that would cover, we can't go through everything in 20 minutes, but would cover a lot of the high yield topics that the American Board of Dermatology finds relevant for residents to learn in preparation for the boards. So these are my 2 out of my 3 kids. The middle child is holding his baby brother, and he looks like a bright-eyed toddler who's ready to face the world and protect his brother. And I remember when he was that young, and We were trying to figure out his learning style and trying to figure out how to help him through school. And we had teachers who were concerned about the fact that he was a daydreamer and loved to like draw and loved crafting, and they wanted him to focus on his work. But he just graduated valedictorian of his middle school, so he's come a long way. And we did a lot of work with him, but everyone isn't born memorizing everything they need to know for their exams. The preparation is important, is what I'm trying to get at. Studying is a good habit. Not waiting to the last minute is a good habit. Little steps at a time build up on each other, and then you're going to have a brilliant result. And I want that for everyone who's attending this lecture. So again, because of our limited time, this is a high-level overview. We'll go through board categories. There are medications that the board wants you to be aware of, both what they're used for and the cautions you should have with certain medications. There's some diagnoses that we'll talk about, and then there's some subspecialty nuances. The biggest proportion or percentage of the board's questions are medical dermatology, and then there's a subsection for pediatric dermatology and a subsection for surgical and dermatopathology. So a little parts of those are sprinkled in through the questions, although not explicitly in some cases. And then time management is one thing I want residents to be aware about. Just as with working with my kids, if you don't get the answer right, don't get stuck. Move on to the next question and move on to the next question and move on to the next question. And then if you have time, go back to the ones, because you don't want to lose the whole day or get frustrated with the exam if you get stuck on a question that's difficult. It's okay to let those ones go. I know we want to be perfect, but it's okay to let those ones go and work through the exam as much as you can and then review when you can. So here's a question. If you have a patient who's presenting with purpuric papules in an acral distribution, and you're counseling the patient, thinking about the diagnosis that will present in this way, what potential exposure for their pregnant partner would be a problem? So the options would be the associated nutritional deficiency. So think about the deficiency that could present with purpura, an underlying viral infection. Are there any that present with acral papules? Are there any that would cause harm to an unborn child? The typically related malignancy, are there malignancies that present with purpura, or the causative traumatic activity? So in this case, the viral infection will be most pertinent to the pregnant partner. All of the listed choices can present with purpura or petechiae. As in the case of scurvy, which is a deficiency of vitamin C, you see perifollicular petechiae in these patients, but that would really have no transferable risk to a pregnant partner. Likewise, a malignancy like Kaposi sarcoma or pigmented purpura like cutaneous T-cell lymphoma may present with acral purpura, but there's no transferable risk associated with that condition. You can see purpura after activity, repetitive activity like running. Usually it would be on the feet more so than on the hands. And you never know who's preparing for the Olympics at this time this year, but there's no reason why having talon noir, for example, this is when you see purpura on the feet after sporting activity, there's no reason why that would cause any concern for a pregnant partner. So the viral infection, parvovirus B19, would be the best answer here. It causes the papular purpuric stocking glove distribution of lesions, and parvovirus B19 can cause asymptomatic infections. However, it can also contribute to a number of unfortunate sequelae for an unborn baby. It can be a cause for hydrops fetalis. It can be a cause for fetal loss. It can be a cause for pancytopenia. And so this is one of those where if a patient is diagnosed with a parvovirus B19 infection, which you can screen for on labs with testing for the immunoglobulins associated, then you would have them essentially quarantine. I know we don't like that word, from a pregnant partner to avoid transfer. The risk goes down the further along the pregnancy is. So caution would be advised in your counseling for this patient. Here's another question, and you guys can harken back to the contact allergy lecture that we did. Which of the following is a contact allergen that's improperly matched with its edible exposure? So normally contact allergy literally means, contact with the skin and the allergen, triggering the immunologic cascade that presents as a pruritic dermatitis. But some of the contact allergens for which patch testing can confirm, true allergy may also be present in food or drinks. And then if a patient who has a confirmed contact allergy to one of these things and consumes the allergen, usually that burden going through the mucosa can cause an allergic reaction that presents with inflammation basically around the perianal area, or a generalized contact dermatitis or erythroderma. So the choices here are nickel in tres leches cake, cobalt in dark chocolate coated apricots, balsam of Peru in a cinnamon cruffin, or fragrance mix one of vanilla ice cream. You guys can chime in if you want. Are there any here that you think would be? So this is improperly matched. Yeah. You're correct. So nickel is usually found in chocolate. It's found in walnuts. It's found in oatmeal, lentils. It tends to be found in similar places as cobalt and sometimes chromium, but it's not typically in tres leches cake. That's a milky cake that may have some cinnamon and balsam of Peru associated with it, but not typically nickel. So nickel typically would be in a question stem that talks about chocolate cake, hot cocoa, red velvet cake. So that's the correct answer, would be nickel. All right. Here's another question. Which of the following treatments would be most appropriate for a patient who has hidradenitis suppurativa and has not responded well to doxycycline? So this is just one of the questions on therapy. There are step therapies defined for different conditions, and the American Board of Dermatology and our what we used to call Blue Journal, JAMA Dermatology, all have consensus statements on certain conditions that the residents or our learners should be aware of. So in this case, if you start a patient with hidradenitis suppurativa on interlesional Kenalog and doxycycline and topicals and they're not responding, the next antibiotic combination that you would go to would be clindamycin and rifampin. And there are a number of studies that show 300 milligrams twice a day of these medications can offer relief to some of these patients in increasing the latency between flares. And then the next step up from that would be to go to a biologic. Cosentyx and Humira are approved currently. And there are other medications in the pipeline that are going to show up for hidradenitis, but this would be the right answer in this case. The other combinations are used for other diseases we see in dermatology. Typically, clindamycin and cephalexin you wouldn't combine. Ethambutol and rifampin you use for tuberculosis. And then clarithromycin and streptomycin is sometimes used for generalized granuloma annulare. So here's the fourth question. For a patient presenting with eye pain, tinnitus, and segmental facial depigmentation, what would be your next step in management? Would you initiate a topical JAK inhibitor for the facial depigmentation? Would you order an MRI and refer them to ophthalmology? Would you schedule narrowband UVB again to assist with repigmentation? Or would you counsel them regarding the risk for a melanocyte transfer procedure? So here we're looking at a patient who's presenting with vitiligo, but in this case, there are some systemic signs of inflammation accompanying the vitiligo. And importantly, the vitiligo is segmental. So topical JAK inhibitors, while being effective for vitiligo, are actually specifically indicated for non-segmental vitiligo, so they wouldn't be an appropriate choice. Yes, you would do narrowband UV phototherapy, but if the depigmentation is limited to the face, it may not be the best first-line therapy or the best next step. It will be something to consider in treatment choices, but may not be the best next step. And then the melanocyte transfer is a procedure that can be done for a stable vitiligo. But the next step would be to try to address the eye pain and tinnitus that the patient is reporting. So this is a case of a patient who has Alexandrini syndrome, which is like or considered to be a unilateral form of void coronary Hardy syndrome. These patients have segmental inflammation, not just of the skin, but the underlying structures. And so you'd want to image and make sure that those are treated, because you can have permanent vision loss if you don't address the inflammation that's occurred. So here's another question. Which of the following is not a long-term risk of lichen sclerosis? So lichen sclerosis is another condition that can be seen in both pediatric patients and adults. It tends to be a chronic autoinflammatory condition. There are some treatments available, but we don't have anything that's guaranteed to be a cure. And given its chronicity, there are sequelae to think about when you're facing a patient with this condition. So the choices here are dyspareunia, constipation, squamous cell carcinoma, and renal failure. And yeah.
Is it renal failure?
Correct, yes, renal failure. So the best answer would be renal failure, which is more of a concern in patients who have systemic sclerosis or scleroderma. Lichen sclerosis is typically limited to involvement of the genitalia, the perineum, the perianal area. You can have extragenital lichen sclerosis, but it typically does not involve other internal organs. Older patients or adult patients tend to complain of dyspareunia, and the worst case scenario would be the squamous cell carcinoma. The constipation is actually a very common finding in children. A lot of times the constipation leads to the diagnosis of lichen sclerosis. Children may not be able to communicate exactly the symptoms they're feeling in the areas where they are affected, but because they have discomfort when they use the bathroom, they tend to withhold and then develop constipation, which may be the presenting complaint. Here's another question. Which infection listed is improperly matched with its vector? So we have leishmaniasis, tularemia, onchocerciasis, and myiasis. So these are all vector-borne diseases that have skin signs that dermatologists should be familiar with. Some of them are endemic to certain parts of the United States. Others can be seen in patients with a history of travel. So typically you have the infective organism, you have the vector that's transmitting the infected organism, and then you may have a host or more than one host involved in the life cycle of these microorganisms. So in this case, you would want to make sure you recognize the disease. You want to make sure you recognize the infective organism and then the vector. So the correct answer in this case would be D. So for leishmaniasis, especially the New World form, the sandfly is the vector. For tularemia, the deer fly likewise, and for onchocerciasis, the black fly. For myiasis, the infective organism is the Dermatobia species, but the vector is the mosquito. So that's the difference there. You want to keep that in mind again and make sure that you're answering the question that you're asked. So if you're reading very quickly through a question, you might see two things that match in the same category in your brain, but they may not be the necessary connection that the question is trying to get you to make. So make sure you always read your questions and your answers correctly, okay? Right, which of these disease-causing microorganisms is typically encountered following exposure to a sandy beach? So we're in summertime, a lot of people travel during the summer, and we tend to see a number of travel-related dermatologic diseases towards the end of summer when kids are going back to school or adults are going back to work after a vacation. So we need to be familiar with certain skin conditions that are found in certain exposures. There's some specific to exposure to seawater, fresh water, brackish water, and a sandy beach. So this question is going after what would you encounter on a sandy beach that would cause as a dermatologic finding. So Ancylostoma brasiliensis causes cutaneous larva migrans. Typically, if you're barefoot on a beach, you could encounter the microorganism in the excrement of dogs. Wuchereria bancrofti causes elephantiasis and is usually transmitted by a mosquito. Loa loa is transmitted by chrysops, the deer fly, which also transmits tularemia, like we just talked about. And then draconiasis causes, it's also called the guinea worm, and it causes an infestation after exposure to water containing copepods that have the worm in it. This is the worm that has to be twisted out of the furuncle that it's located on in the skin slowly in order not to break off a piece of the worm and then cause a severe inflammatory reaction in the skin. So here's a question about a drug. Which of the following is an FDA-approved treatment for molluscum contagiosum in a 1-year-old? We know that for pediatric patients, a lot of medications aren't necessarily FDA approved and are being used off-label, but there has been a move in recent years to get a lot of medications properly approved so that there's access improvement for patients. It's usually more difficult for families to have access to medications that are not technically FDA approved for the child's age group, but there's some now available for molluscum that fall into this category. The options are YCANTH, Vyjuvek, Bordazima, or imiquimod. So the correct answer here is the Bordazima gel. And it has to do with a difference in the age group. So imiquimod is what we've used from warts and molluscum for a very long time, but it's actually technically approved for patients 18 and older. YCANTH is approved for patients 2 years and older for in-office application of the cantharidone solution. The Bordazima gel is approved for 1 year and older. So in this particular patient, as described in the question stem, that would be the best treatment choice. So moving on to some genetics. Which of the following familial cancer genes increases risk for malignant melanoma? So as dermatologists, we're trained to be very familiar with melanoma. And when you see a melanoma that's especially aggressive, involving multiple sites, or in a particularly young patient, you always have the question in the back of your mind as to whether there are risk factors, whether inherent or acquired, that would trigger the melanoma. The most common acquired risk is UV exposure, especially tanning bed use. And there are a lot of states now that ban children from using tanning beds or require specific parental consent. But the things you can't really control beyond UV exposure and tanning bed use would be an inherent genetic predisposition. So the choices here would be CDK4, CDKN2, the SUFU patch 1 genes, HRAS, KRAS, or the MSH-MLH complex. And the best answer here would be the CDK4, CDKN2A genes. This causes the familial multiple mole and melanoma syndrome. SUFU and patched are seen in patients with multiple basal cell carcinomas, in the nevoid basal cell carcinoma syndrome. HRAS and KRAS are seen in Schimmelpenning syndrome, in epidermal nevi, and some of those carry risk for bladder cancer, especially when it's a large segmental involvement and not just involvement in a small area of the skin. And then MSH-MLH you see in patients that have sebaceous adenomas and essentially a form of Lynch syndrome, where they can have GI cancers, breast cancer, thyroid cancer, and a host of others. So in this case, for the malignant melanoma, the CDK4, CDKN2A would be the best answer. ATP2A2 mutations can be associated with what nail findings? So, as dermatologists, we're experts in both the hair, skin, and nails. And we recognize patterns in the nails that trigger us to look for other things on the skin or in the history that may indicate more than a simple nail problem. So the choices here are longitudinal melanonychia, linear erythronychia, lamellar onychoschizia, and leukonychia of the lunula. So in this case, the linear erythronychia would be associated with Darier's disease, which has a mutation in ATP2A2. Longitudinal melanonychia can be seen in Laugier-Hunziker syndrome or in Cronkite-Canada syndrome, the former of which may be associated with GI polyps. The latter of which may be associated with GI polyps. Lamellar onychoschizia is just the nail splitting that you can see with chronic wet work, so it would be an occupational exposure. We can sometimes see it in children who suck their fingers or thumbs. And then leukonychia of the lunula may have a few different causes, including trauma. An otherwise healthy 10-year-old presents with patches of non-scarring alopecia, and you estimate that about 50% of the scalp is covered. What would be the most appropriate treatment for this patient? So again, we have a patient with severe alopecia areata. The patient is 10 years old and otherwise healthy, and the choices here are oral sulfasalazine, topical JAK inhibitor, oral JAK inhibitor, or topical minoxidil. So here, this is another one of those cases where the board wants you to be familiar with the ages of approval, the official ages of approval for medications. Again, we know that in dermatology, sometimes when we're trying to help a patient who has a severe case, we might reach for something that's not necessarily approved and use it on an off-label basis with counseling. But of the choices here, oral sulfasalazine is a medication that can help improve severe alopecia areata and is a medication that's approved for patients age 2 and up. The topical and oral JAK inhibitors have shown great promise for severe alopecia areata as well. However, they're only currently approved for patients who are 12 and older. And then topical minoxidil, again, we've used this for a long time on and off label, but for a 10-year-old, technically it's only approved for 18 and older. Here's our next question. This has to do with some derm path. So on electron microscopy, if you're looking at a picture of equine zebra bodies, this can be associated with a specific genetic syndrome. The question here is that for that syndrome, which cutaneous and systemic findings would you expect that would be linked with zebra bodies found in the equine glands? So choices are the patient would also have cherry angiomas and hypercholesterolemia, or they would have telangiectatic mats and pulmonary embolism, or a risk for pulmonary embolism. Would it be a patient with prominent forehead veins and wasting, or would it be a patient who has diffuse angiokeratomas and cardiovascular disease? So in this case, we're talking about a patient who has Fabry's disease. And so with Fabry's disease, these patients tend to have angiokeratomas, which are deep red to black papules, typically in quote unquote a bathing suit distribution. So along the trunk, flanks, and waistline. And if you were to see those should be an indication to screen for and monitor for cardiovascular disease, which is the usual cause for both morbidity and mortality in those patients. You would see prominent forehead veins and cachexia in an accelerated aging disease like progeria. You'd see the telangiectatic mats and pulmonary embolism in hereditary hemorrhagic telangiectasia syndromes. And then cherry angiomas are a very common finding in older patients. They're acquired over time. And when a patient has numerous, talking in the hundreds, there has been an association with hypercholesterolemia. Here's another question. A patient you're seeing with severe anemia should be referred for, you should order an abdominal ultrasound if they also have which finding? Would it be multiple angiofibromas, cutaneous leiomyomas, sebaceous adenomas, or sporadenomas. In this case, it would be the leiomyomas because cutaneous leiomyomas seen along with uterine leiomyomas can be associated with Reed syndrome, and the uterine leiomyomas can lead to severe anemia due to menorrhagia. Multiple angiofibromas would be seen in tuberous sclerosis. Sebaceous adenomas would be seen in Muir-Torre syndrome. And then sporadenomas can be seen either sporadically or as part of Brooks-Spiegler syndrome. Next, you're seeing an 18-month-old who presents with hyperpigmented, asymptomatic subcutaneous nodules on the thighs. If you see these and there's no history of trauma, and again, they're asymptomatic, this would suggest exposure to A, lead, B, zinc, C, copper, or D, aluminum. So thinking about the exposures an 18-month-old would be subject to, aluminum would be the best answer, and this is a description of vaccination granulomas. A lot of times, nothing is seen immediately after the vaccination is administered. The thighs are a common site for infants and toddlers to get their vaccinations. They may have erythema and swelling in the area for a few days. Usually the pediatrician counsels to give Tylenol if the patient is uncomfortable. And it's typically many months after that the family might point out dark spots on the thighs, especially if it's a patient with skin of color. And those are typically these benign granulomas that resolve on their own. Here's our next question. In a patient presenting with plantar keratoderma, which gene would confer risk for gastrointestinal malignancy? So the ichthyoses, the keratodermas are another group of diagnoses that the board wants our residents to be familiar with in preparation for their exams. There are a series of palmoplantar keratodermas to be familiar with. I will tell you that all the answer choices are associated with the palmoplantar keratoderma. The question now is which one is also associated with risk for gastrointestinal malignancy. So the choices are keratins 1 and 10, the RHBDF2 gene, SLRP1, or cathepsin C. And the best answer here would be the rhomboid proteinase or RHBDF2 gene. It's associated with a syndrome called Tillosis esophageal cancer. It has the British spelling, so that's why it has an O instead of an E. These patients have a focal keratoderma that's sometimes painful and tends to be found on pressure points of the feet more so than the hands. Keratins 1 and 10 are mutated in epidermolytic ichthyosis. The SLRP and cathepsin genes are mutated in the so-called fetid or stinky palmoplantar keratodermas, which may also have gingivitis associated in one of them. So 16, which of the following is not a target for biologics effective in psoriasis treatment? So we know like biologics are like the new wave in dermatology. We have a lot of them with a lot of targets, the aim of which is to give our patients as much efficacy as possible while minimizing side effects. And of the ones listed, one is not even a target for psoriasis currently. You guys have it? Yeah. A, yeah. Our residents know it. Yeah. So IL-13 is the target for dupilumab, lebrikizumab, and tralokinumab. And it's a cytokine that contributes to atopic dermatitis, is not really as functional in psoriasis. The others are targets for psoriasis treatment. What about this one? Which of the following is an FDA-approved treatment for systemic lupus erythematosus? And the choices are anifrolumab, dupilumab, golimumab, and ocrelizumab. A, yeah, that's correct. So anifrolumab is an FDA-approved treatment for systemic lupus. Dupilumab, like we just spoke about, is indicated for atopic dermatitis. Golimumab is for psoriasis, and ocrelizumab is for multiple sclerosis. So we talked about aluminum granulomas in babies who received vaccines. You can also have granulous reactions in both teenagers and young adults, sometimes older adults. Sometimes reactions to tattoos can present with a dermatitis acutely or a blistering disease or with frank granulomas. The question here is, which particular tattoo pigment typically causes a granulomas tattoo reaction? The options are cadmium yellow, melamine, paraphenylene diamine, and then cinnabar red. Yeah. Cinnabar red. So all are dyes that are used for both temporary and permanent tattoos. Cadmium yellow is associated with photoallergic reactions. Melamine is used in invisible tattoos and can cause a contact dermatitis-like reaction. PPD is seen as an additive in henna in temporary tattoos, and it can cause a variety of reactions. With patients that have severe allergy, they can react even if they're in a room where other people are applying the henna tattoos and they go in that room. When PPD is found in hair dye, sometimes it can cause a blistering reaction on the scalp or even a flu-like presentation. But cinnabar red is the one that has been associated with tattoo reactions featuring granulomas. So here's, we're almost at the end, a couple more questions. And expected cutaneous finding in a child with a hoarse cry at birth and bilateral medial temporal lobe calcifications is palmar pits, distichiasis, collagenomas, or fat herniation. So you're being presented with a typical clinical sign and a radiologic sign, and you want to think about which condition will have both of those, and what skin finding would you see in a patient with that condition. So the correct answer here would be the distichiasis, which is seen in lipoid proteinosis. Palmar pits are seen in nevoid basal cell carcinoma syndrome, and those patients present with a calcified falx cerebri on X-ray or MRI. Collagenomas are seen in Cowden syndrome and Buschke-Ollendorff, and then fat herniation can be seen in Goltz or focal dermal hypoplasia, and those patients will present on X-ray with osteopathia striata, where there are striations in the long bones. Buschke-Ollendorff would present with osteopoikilosis, where there's spotting in the long bones near the epiphyses. All right, so supplements and vitamins are hot right now, and everybody's taking them for a variety of reasons. We do have patients who ask us about, what they should take to supplement either for their hair loss or acne or psoriasis or vitiligo. And there's a lot that's marketed to our patients directly online and on social media. There have been cases where patients have purchased particular vitamin combinations on social media and ended up in situations they weren't expecting. And that's kind of what this question is based on. So excessive provitamin A, beta carotenoids, preformed vitamin A or isotretinoin consumption may result in what change or what harm to a fetus. The options are microcephaly, macrocephaly, macrodactyly, or micronychia. So it would be microcephaly. So there's a whole isotretinoin embryopathy syndrome where the patients can have microtia or a small ear, anotia or no ear, cardiovascular defects, cardiovascular structural defects, and they can also have microcephaly. So typically you may extract a history of isotretinoin exposure if you were consulted, for example, on a baby who had features of the embryopathy syndrome. However, there have been a few cases of patients who never took isotretinoin, but were taking a quote-unquote acne vitamin that contained excess vitamin A and had the same outcome. So it's very important. I think we've been counseled in some recent articles to ask our patients questions about not just the prescriptions that they're taking, but any supplements that they're taking for any health reasons, because those may be contributing to both their presentation and outcomes. So that's all I have, Dr. Bree.
Oh.
I'll be happy to take any questions, and you guys can ask any questions too if you want.
Yeah, any questions, ladies, being taught back there by one of the best of the best?
Yeah, do you have any questions?
Yeah, with that question, I think it was like the vector and then the
Yes.
and the disease.
Yes.
You were saying that the Dermatobia hominis one was not correct because it was not the vectors and mosquito that was vector.
Correct.
Okay.
Yes, yes, yes. So for myiasis, the question was about myiasis. The myiasis is caused directly by Dermatobia hominis in the US. There are a few other species that cause it in other countries, but it doesn't penetrate the skin directly. So typically the adult is a fly and the maggot is what infests the skin. But for the maggot to get to the skin, the fly lays eggs on a mosquito. And then the mosquito takes a blood meal, and while taking the blood meal, those eggs are shed onto the skin, and then the maggot hatches in the skin and forms the furuncle. So the vector for transmitting the microorganism is the mosquito rather than the Dermatobia hominis itself. Yeah.
Yeah.
For
So
the next one you did with the Ankylostoma brasiliensis.
Yes.
So you said it's water containing coffee pods, is that?
Coffee pods. Yeah. So COPEPODS. Coffee pods are tiny crustaceans. They're microscopic crustaceans that are found in quote unquote dirty water. They're part of the organisms that normally would be swimming around, but they also can be vectors that the worms will live and grow in. So if someone who had the infection bathed in that water, right, the worm would leave their skin and infest the coffee pods. And then if you don't have the infection, but then you came and waded in that water and happened to have the coffee pod either come in contact with your skin, that gives the worm a chance to transfer to you and then burrow into your skin and start its life cycle again.
Oh, wow.
Yeah.
That's wild.
Yes. So there are a number of things lurking in the waters out there.
Yeah.
You know,
So
maybe we should do a whole
water.
water beware of the water dermatology thing, you know. My little guy loves water and water creatures and he would be all over it, but there's a whole series of, you know, stings from jellyfish and, you know, the swimmer's dermatitis and sea bathers eruption and coral, and there's a lot lurking out there that we could get into. Maybe we're thinking about a new topic. Yeah.
Yeah, and that can have a surfing theme as well.
Yes, yes, it would. Yeah. So I
love
mean,
it.
so grateful to be able to talk to you again about this and try to get a little bit of prep for our residents as the boards are coming up soon. Yeah.
Yeah, yeah, and I love learning from you. I used to be your teacher, but you've always been my teacher, and
Oh, you still are. I mean, the great thing is we get to learn from each other. We get to learn from our patients. And I think we love our job because every day is a chance to learn something new, you know?
Amen, amen. And
Yeah.
yeah, good luck to all the residents taking the boards. We all wish you luck.
Yes.
I'll be praying for you guys as I always do, that you're learning and growing and that you're going to go out and take good care of those patients. But thank you, Dr. Agim. We will
Oh,
definitely
you're
be doing
welcome.
another talk.
Yes.
And again, good luck to everybody. Yay!
Thank
You can do
you.
it. Thank
Thank
you.
you.
All right.
Bye.
Bye-bye.
Bye.